Okay, so in the effort to keep on time, I think we'll get started. I wanted to begin right after lunch with just a brief commercial announcement. I put up on the screen the cover of a document that was created by a national consensus panel trying to identify, if you had a system of care for children with chronic health problems, what that system ought to look like. And so this exists at the website for AmChip, and it exists at our foundation website. It's in the process of being shortened and revised, and a variety of other related materials, like how to do a self-assessment related to these standards, is in the process of being developed. But I wanted you to know about it. These are the categories, the domains in which all those standards fall. And so this is just an FYI that these exist. I'd like to, as we move forward with the Foundation's work, identify a set of standards for complex care clinics, so that you could define what you are capable of providing and therefore be able to argue for better reimbursement. If you're existing as you tend to exist now, it's a primary care clinic, you get primary care rates and you lose money. So I think being able to document some standards for what a clinic ought to be able to provide would be a good step toward increasing the sustainability of complex care clinics. So that's it for the commercial, and we'll move into our next panel. Debra?
Great, thank you. So it's my pleasure to be the moderator and facilitator for our panel on models of co-management and team care. And as previous facilitators have said, you can read the bios of our esteemed panel. And it's my pleasure to present Dr. Ferris.
Thank you. Well, it's a real honor to be here. I've learned so much already. I take notes, as I've seen many of you do, and my notes are packed, notes and quotes. So it's already been very productive for me. So thank you, Ed, so much for the invitation, and to the Lucille Packard Foundation for doing this. So thank you for inviting me. Let's see, I've got my notes here. Also, it's really fun. There's a lot of people I haven't seen in years. I did my residency with Richard Pan. I haven't seen him in 20 years. That's sort of fun. And also meeting a lot of you where I look at your name tag and say, oh, I've cited your papers in my work. So that's really fun too. So thank you so much. And then I just wanted to also thank Melinda Abrams. Is she here? I don't see her right now. Melinda? Oh, she left. So Melinda she was here this morning. Melinda funded a lot of the research that I've done on complex care management, and I just wanted to point out, maybe it's actually better to say this when she isn't here, right? That because she is an incredible force for good in the universe in what she does at the Commonwealth Fund. She's been focused on this issue for a really long time. She has a lot of patience and a lot of perseverance, and when I get funding with her, what I do is better because of her close input with all the work that I do. So I just wanted to say that about Melinda. And then also I have to say, this is going to come out of the blue for Dr. Boat, but Dr. Boat probably doesn't remember this, but I was selected by AMSPDEC for a fellowship 24 years ago. That fellowship funded my work and got me started in health policy and health services research. And I remember at the time, I was the first fellow under that program who was not a basic scientist to get funded. And Dr. Boat made an impassioned plea that this kind of work was equally valuable to society and that should be funded. So I want to just thank you so much for something that occurred a long time ago. Yes, exactly. Good. Yes, I hope nothing has happened since that has changed your conviction. So So I was just, a couple other people to thank. Clemens Hong, the research that I'm going to talk about, I do with Clemens Hong. He is now, sad for me, but good for LA. He's running a very large randomized trial for the LA Department of Public Health in community outreach workers for the entire county of LA. It's a really very exciting opportunity for LA. He's been instrumental in the work that I've done. And then obviously, as Susan referred to me, Susan Edgman-Levitan, who's here somewhere, she referred to me earlier, and so I'll refer back to her. We work as a team and all this stuff. And then finally, I have to say that I was thinking about two different slide decks to show here. And after being here yesterday and this morning, I chose the wrong slide deck. So this slide deck is unfortunately really, really repetitive. I mean, with the Chris back there, all those two great Chris presentations, like this is really, really repetitive. So I'm going to go a little off script and not follow my slides. I should have picked the other slide deck, which I think would have been maybe more interesting because it talks about all the work I've done in adults. And I'm a med-peds trained doc, and so have done complex care management programs in both adults and kids. And maybe the challenge that I would put to the audience is, well, Jim Perrin, an early mentor of mine who's here, beat me over the head with the 4Ds, because it was 4Ds back then, and then it was 5Ds. Actually, as a med-peds doc, I'm more of a lumper than a splitter. I see more similarities between what I do in adult complex care coordination and pediatric and a lot of people here have stressed the differences. I would tend to stress the similarities, but hey, different people, things are, it's not worth arguing about. But it is interesting, the different perspectives. I see the 4Ds in the context of complex management as differences in degree more than they are differences in kind. Like dependency, so my older stroke patients are just as dependent, right? So, and then I wanted to say one thing about the other thing I've heard at this talk, which I maybe be a little confrontational, not confrontational, press you about, is there's been a lot of discussion about the science here, and the importance of the science and the need for the science and to get rigorous and all this stuff. And boy, I 10 years ago when I moved to the dark side and I went from being a health services researcher to being the medical director at Mass General, initially my impression of management was, oh my gosh, they use data terribly. They're not really good about understanding the data they're using, and they make decisions really quickly with really poor data because they have to. That's what their jobs are. And initially, as a researcher, I was really sort of, gosh, they are, like, it's amazing anything gets done well, right? Because I was really focused on, what is that point estimate of that difference there? I will say I'm now, it's been 10 years in management now, I'm a little bit more in the management camp of, is the point estimate that important? And let's just get something done. The coin of the realm for academics is being right. The coin of the realm for management is getting it done. And so I just finished reading David McCullough's Wright brothers book, and of course we all know about this story of the Wright brothers. But there was one element to it that I thought was really appropriate to this, which is, the Wright brothers, they went and interviewed a number of people. They were not just, bicycle mechanics. They were pretty bright, and they did their research, they did their homework, but then they realized that the homework and the research was only going to get them so far. And if you've read how many have read this book? It's really it's a wonderful read, and it reads very quickly. They then just went and tried it, and they did glider test flights over 1,000 times before they even put an engine on it, right? And it was totally empirical. Right. Meanwhile, the government was funding Langley at an extraordinary rate, and his birds, just a few hundred yards from here, dropped into the Potomac River. They didn't fly at all. And he was being sort of the very academic approach. And the Wright brothers had just try it again, test it again, try it again, PDSA, right? And so that's sort of where I'm coming from with these programs. There's a lot of theory, but the big issue is we have to improve care coordination for people who need it. We know it can be done. And so when I get policy people saying to me, where's the evidence base? Where's the evidence base? I'm like, has anyone ever done it successfully ever anywhere? That's the test that I need. Because if they have, then I can do it again, right? So that's, and I'm a little, the things around standards, I worry that the heterogeneity in our delivery system makes developing standards, unless they're at a really high level, really tough. Because we're putting in place, as Susan said, the patient-centered medical home standards, and we decided to do it because we needed an external validation source, but that in and of itself isn't going to deliver on what we need. And so the standards are useful, checklist, yes, they get us all roughly on the same page, but it's not necessarily, it's not a panacea for sure to have those standards. So those would be my observations about sort of the conference so far. So let's talk a little bit about what we're doing at Partners in terms of a specific example. And I'm going to start, I'm going to go through these slides, unfortunately, maybe good, maybe bad, at lightning speed, because this isn't the slide deck because you've seen almost everything. It's just stated differently. My graphics aren't nearly as nice as Chris's back there. I was and the stuff you saw from Denver. So too many words on a page. Medical complexity, kids have medical complexity, it's a problem. I just keep going here. Requires greater skills and resources, right? You all know this. There's all kinds of legal complexities with guardianship. Again, I see those with my adult patients. Alternative living arrangements, finding adult physicians comfortable with caring for childhood diseases. We do a lot of this with our med-peds doctors, as I was trained, because they've seen it in the kids and can follow it. That's a nice thing that we have. So one of the things, and everyone has different lists of what the wraparound is, what it is you need. And so this is our list of both the medical services. The medical services, there's no surprises there. The community support services, this is a critical piece of this, and this is something we've learned, and you guys have Rita has said this, a lot of you have said this, again, I'm just repeating. But what we found was necessary and very practical is we created basically a data set that is web enabled, that allows anyone, any practitioner of any type, social worker, whatever, to search for community support services under 15 different categories of services and search by zip code. And so basically what we're trying to do is match services. We are not trying to provide services. We can't afford to provide services. So this is what our social workers and our psychiatrists and everybody else said. What we really need is we need to be able to connect people with local resources. There's tons of local resources out there. We've now hired and trained the people to make those connections, that care coordination, but we need actually a web-enabled resource that allows us to what is the Elder Services Program, what is the Title V program, what is the program in your neighborhood. And so that's something that we've done. What's sort of nice for us is the state got wind of it, and the state is actually, we're donating it to the state, and the state is enabling it, and they're going to create a statewide database using ours as a foundation. So emulation is the sincerest form of flattery, right? So we are very happy to give that away. So the current model, so this is just my sort of simple heuristic. So we have a care coordination, in-hospital care coordination clinic for really sick kids, so that when they come into the hospital, as many, I've already heard, this is nothing, it's not rocket science. It's basically bring them into one spot and then have the specialists come and meet with them so that they're not having to coordinate around. So that's one piece of it. it does tend to be focused on the technology-dependent kids and the kids who really have a lot of medical issues. Our care coordination program, our primary care embedded care coordination program, serves those kids and plugs them into the clinic, but also serves a bigger set of kids. And these are a lot of the kids where, as you saw in prior presentations, where the social needs were really predominant. Yes, they have medical problems, but their barrier to getting great care is not necessarily their medical problem, it's the social situation in which they live. And that's what our primary care embedded care coordination program is for. And now I've done something that has stalled me. Is there some way? There we go. Thank you. So here's the big difference, and I have some slides on this, but I'll just get to the point. The big difference between adults and kids is the epidemiology of disease from a care coordination perspective. And the fact is that when we run our risk identification algorithms across the 500,000 patients that we care for in our risk, that we have financial risk for in our system, when I look at a commercial population, our algorithm identifies 3% of a commercial population. This is all adults and children. I'll get to the PEDS dissection in a second. When I look at Medicare, that same algorithm identifies 9% of the population. And when we do Medicaid, it's 5%. So Medicare is the highest, then Medicaid, and then commercial. Now, when we split that out by Medicaid and commercial, because we don't have a lot of kids in Medicare, you might have noticed that. But when we split it out by Medicaid and commercial, we identify 0.5% of kids in commercial and about 1% of kids in Medicaid. That's the way our algorithm works. Our algorithm is based on, again, I have some slides on this, but it's more fun to just talk about it. Our algorithm is based on, it first uses a claims-based algorithm. I don't know, Jim, what it's called. I call it the Jim Perrin because he gave it to me like 20 years ago. But that's why it doesn't work. Right. But basically, it identifies for our kids, and then for adults, we just use a standard risk adjuster. We identify like DXCG or whatever ETGs. It doesn't matter. I've tested 6 of them in head-to-head trials. They don't perform particularly differently. They've all pretty much maximally extracted what's available in claims. And so you pick whatever one you want. But then we do two things. So we risk stratify the entire population based on a single process. Then what we do is put it through a screener for our vision of what is manageable versus not manageable. So what we're looking for mostly is chronic illness, mental health, all the things that require management, as opposed to, say, trauma or cancer. Like kids with cancer in our system, they get extraordinary resources. We do not want to have embedded, care coordinators in our inner city clinics managing the kids who are getting just unbelievable resources thrown at them through the cancer center. So we don't do cancer because at least in our system, they've got like way more than we could ever offer them. So, we first do claim stratification by risk. Then we do a screener for diagnoses that present management challenges. And then we do a third step. And the third step is a really important step. This is what Clemens Hong in his research, his publications, by the way, if you Google Clemens Hong, he's got 4 or 5 publications on this stuff. Including a California Healthcare Foundation that compares different systems risk algorithms, identification algorithms. The third step, we actually put the lists of ranked high-risk patients in front of all the PCPs. So we sort the list in the 233 practices that we do this across Eastern Massachusetts. We send the list to the docs and we say, is this right? And what's really interesting about that process is frequently, and I get these lists for my panel of patients, and sometimes it'll, you sort of scratch your head and say, why is that person on the list? And oh yeah, they do have multiple chronic conditions, but they are so all over it. They do not need our help. Like we couldn't possibly add it's sort of like, what Susan said about having rheumatoid arthritis and having a care coordinator call up and like Susan can teach that care coordinator everything, and just it doesn't need it. And so some of the people we scratch off the list as PCPs, and then some of the people said, yeah, the rest of them, they look right, but you're missing a few that, and it may be you're missing a few because actually I'm sweating bullets keeping them out of the hospital. And because I've kept them out of the hospital, the risk identification never identified them, right? And so they really need care coordination, but just because they've been in a quiescent period or for whatever reason, or I've been working really hard, they need it. So that last step has been really important for two reasons. One is I think it's more accurate in terms of the distribution of resources. And the second reason is it's incredibly important for physician buy-in. So when we first did this, and we told the doctors who was going to be in the care coordination program, they looked and said, wait, and I think I've heard this from several of the comments already, the speakers like, you're telling me which patients need to be in this program? No, I'm telling you, right, which patients need to be. Like you work for me, not the other way around. So what we've done is we've come to because honestly, if you let physicians just decide by their own, they just keep putting more and more people in, and their threshold goes down and down and down for who could bet. Well, Susie might benefit from this too. Why not? So we have to hold the strings on that and say, they have to be on the list, but we allow them 5% wiggle room. So they can add 5% of patients they choose to the 200 patient panels that our care coordinators have. So that's the compromise we've come to between sort of the clinicians and the management, which is we can't afford to do this for everybody. There has to be a cutoff. And yet the clinicians have a lot of insight, and so that's the hybrid method we use. I then want to make a comment about ROI, because a number of people have made comments here about ROI. And so I have 9 years of experience doing this. I have a lot of ROI data. Some of it's been published by the National Academy of Science on the adult program. We get a great ROI on the adult program in the Medicare, not in commercial, and not in kids. I've run more than 20 different models on doing this in kids and setting the threshold in different places. It doesn't produce a positive ROI for economic value to management or payer. I can't find it. I've looked for it in detail. I can't find it. I can only find it in Medicare because Medicare patients are hospitalized so frequently. And keeping them out of the hospital is relatively straightforward. That's where the ROI. So I hate to be the downer at the parade here, but I can't find it. And so if that's true, then acknowledging that and working with that instead of against it is probably a good tactic for promoting adoption. But that doesn't mean that it isn't producing better outcomes, right? And I think this is exactly what Rita was saying, which is we are seeing, just phenomenal improvement in satisfaction and decreased stress among the parents, and it really is producing better outcomes. And I loved took some notes on some ideas. Doing outcomes in this population is very challenging. The biggest challenge in this population for doing financial analyses is something that Jim Perrin helped teach me, which is regression to the mean, right? So you are selecting an outlier population to manage. And so the only way you can actually demonstrate, because they are going to decay, they are going to cost less the following year. Absolutely guaranteed they will cost less the next year. The question is, if you have to follow my logic here, did they cost less more? or less. How's that for, how's that for completely ruining the English language, right? And that's a really tricky thing to figure out. I have been working for years on this. When I first did this for 6 years in a large Medicare demonstration project, I had the advantage of a prospective control cohort, which was phenomenal, selected by the exact same criteria. It was a beautiful thing. So that's how we were able to publish a 3-to-1 ROI. But without a prospective matched on an intention to treat basis, doing a difference in differences analysis, it's remarkable I can still put that sentence together, Jim. Managers don't do that too much. That you actually can do this. We're making some progress in our state. Our state health policy commission and another organization in the state that deals with an all-payer claims database is what I keep saying from a policy perspective, and something that can really advance this is if there was a cohort that was produced every year through all-payer databases at the state level that just tracked the sickest patients and what their cost trend was, then I could do annual difference in differences analysis. It doesn't even matter that the criteria aren't identical for the selection process. I just need to know what the inflation rate is among the sickest patients, because the inflation rate among the sickest patients is different than the inflation rate among the total population. And unless you know what that number is, you have something to base it off of, it's very difficult to track. I would say this would be an important policy lever, because it's not hard to do from a technical perspective, at least for all the states that have these claims data sets. But it provides the politicians and policymakers with some degree of reassurance that you're going to measure yourself against something. It's not perfect, but it's better than nothing. And just saying, trust me, this is great stuff, I haven't found a lot of success with that model. So those are I think I'll just stop there. I have a whole bunch more slides. This was much more fun to do it this way. It was just text, and I look forward to the question period. So thank you very much.
Dr. Lail?
Good afternoon. Can everybody hear okay? I want to say a little bit about who I am, because it will explain a lot about what we're going to talk about today. The bio is there, but I have a little bit of a peculiar job history, and back 3 years ago, I was a general pediatrician in private practice for 31 years. And I got to work with many of the faces in this room as we worked through the early 2000s on patient-centered medical home, on NCQA certification, and all sorts of things to build an outpatient system of care in a medical center-rich part of North Carolina, where there were 2 medical centers with lots and lots of patients being referred to a primary care pediatric practice. So I wanted to think about that part of my life, and also what I'm doing right now at Cincinnati Children's, working on quality improvement for the chronic care systems for the whole tertiary and quaternary medical center. When you sort of say, wow, that's a kind of a peculiar story, it is. So I want to thank all of our families who have attended, but I also have pictures of children in this slide deck who are real children whose families have said, yes, please, you have my HIPAA consent to use my child's picture to help everybody understand better. I also want to thank Jay Berry for that astounding briefing, which really almost brought tears to my eyes. So Jay, thank you. That you crystallized it all beautifully. Thank you. So when I was in primary care, we said, gee, we're probably not doing as great a job as we'd like with our children with special health care needs. So we start to put together a system of care, and this became ours because I was not an academic, and I'm not an academic. I didn't publish this, but the American Academy let me talk to a lot of practices around the country, and we found out that these were the things that we had to have to build a system of care for our children with chronic illness. We had to have, and I'll say this first, relationships. And I know there was some comment made earlier today about primary care being a horror show, and I just have to say that that was not what I found it to be. 3 decades of primary care pediatrics, I still get pictures from families, still get wedding invitations, baby announcements, and there's no greater joy. Was it easy work? No. But the relationships are huge. The trust that's been referred to, the attitudes, the culture that has gone on, that's where I want you to focus on that piece. Ready access, the ability to come in on Sunday afternoon, the ability to be seen on Tuesday night. Those were the things that gave our primary care setting, the NCQA certification, but much more importantly, the trust of the families to say, you mean I don't have to go to the emergency room, do I? No, come see me. We had developed a registry, which we started off in a spiral-bound notebook. Later on, transitioned that to the electronic medical record. Developed care coordination initially at 3 hours a week. And now there are, in the practice that I have subsequently said goodbye to, have 3 full-time care coordinators, all of which are a line item in the budget because the physicians said this is so important, it's so helpful that we're going to pay for it. We went to the electronic records in 2007. That is, we did a lot of this work for 5 years beforehand, and then used a very simplistic way of collating our resources, internal and external. And when I say internal, it's important to know that our 2 care coordinators, neither were licensed people. Both of them are actually family members for some of our other families, adopted family members, because they're so important. And the care coordinators are not licensed people, and you do not have to have licensed people doing care coordination. So the external resources were an important collation of what was in our community, who are our school nurses, who's a school nurse at Estes Hills, so that we could work with our community, with our Autism Society, with the lactation consultants, with everyone to be able to help our kids, as well as co-managing with the folks at both medical centers. So we put that together back then in a little pocket notebook that all the doctors carried in their pocket, and nobody no, you can't have mine. Reimbursement was huge. We had to negotiate with both Blue Cross Blue Shield and, is Steve still here, Steve Wagner? We had to work with Community Care of North Carolina to be able to say, these children require more care, help us pay for that, and indeed they did. And then recruitment. We had to say to other people, this is what we want to do. We want to take care of healthy children. We want to take care of children who are at risk. We want to take care of children with chronic conditions. And so I'm going to contrast that a little bit with what I do now, because I'm doing quality improvement at Cincinnati Children's, but I also spend a day a week working in the complex care clinic there. And what we found is that this list that was from 2003 or 4, applies a lot in the medical center. So clearly everybody knows Ed Wagner's chronic care model, and what we've been doing with 29 different condition teams at Cincinnati Children's is building in the components of the chronic care model to support our families. And actually, you'll see great similarity between what we were doing in primary care and what's happening here. We build registries for population management, and these registries, thankfully, are built within the EPIC health record. So that has been very helpful for us for data collection. We're working on improving the outcomes for these children, either the clinical, functional, or patient-reported outcomes. We're working on measuring and improving those. So we begin with the registry. As one doctor said, man, you really can't take care of people if you don't know who you're taking care of. I think that's really right. We also are working with evidence-based to say what outcomes are important, what outcomes are credible, what outcomes are biologically possible, and what outcomes matter to families. We're working on patient-reported outcomes using electronic tablets to have families tell us about their quality of life. We're working on risk stratification and pre-visit planning. And the risk stratification is actually happening at 2 different levels. Rita's tool has been hugely helpful on a population level. If you have 9,000 children with epilepsy, you don't know all their middle names. So it's really important to be able to have an electronic tool to say, of those 9,000, who are the sickest of the sick? Then let's go on a very personal level and say, what is your medical complexity? What's your psychosocial complexity? So it gives us just a little bit of triage. Pre-visit planning is really helping us be able to be ready for the visit, to know what the child needs and to anticipate how we're going to get that accomplished. The needs assessment is being done by care managers. One of the things that the nurses are teaching us is that care coordination is not done just by care coordinators or care managers. All people on the team coordinate care. And some people need high-level sophisticated care, some people just need some support. And I think that's been brought out in a lot of the work around MAs. The parent advisors, we have 42 parents who advise our quality improvement teams, and they have been incredibly clear advisors to say, why would you want to measure that? There's been many a meeting where a parent has changed the whole trajectory of the meeting. And then we're working on self-management support. This is an area that I listened intently because we need to do more on that. We do not have that down pat. But if you look at this and you say, gee, chronic care model, primary care, they're not that different. So I would say that I think in co-management, as we start to work between families and the community, families and specialists, cardiologists and nephrologists, all these things are sort of foundational pieces that really will help us be able to co-manage. The other thing I want to say is that I think we're changing the culture. I think the word was attitude, culture this morning, but it's also about attitudes. And one of the docs at Duke with whom I had felt like we worked particularly well, I said, gee, why does that work? Why has this worked for us? And she said, well, when you send us patients, the patients expect that we'll be in communication with each other and have a sense of comfort that we are behind the scenes somehow connected and working together in their best interest. And I really like that concept of co-management, and it actually just was a conversation. So as we think about changing both the systems and the attitudes, we talked about the systems, registries and patient-reported outcomes and all sorts of things. I think we have to identify our resources, and I had a great conversation over lunch with Dr. Perrin. I really do not want primary care to be left out of this conversation. Jeannie Van Cleven, I just published an article last month about where children should have their medical home if they have a chronic or rare condition. And disturbingly, 43% said they should go to the medical center. And for an old pediatrician like me, that was a little bit of a gut punch. But what I will say that means that there are 57% of our pediatricians who say, send them to me. Let's work together. Let's co-manage. And I think we really need to look at that as a significant resource. And when I say pediatricians, I don't mean just pediatricians. I mean pediatricians, nurse practitioners, nurses, whole groups of people. So I think we have to identify our allies. You know, Peter Block talks about allies as being people who share high trust and high regard, high judgment. You're aligned on those things. And I think we have to find those people. I don't think that every child can go to a complex care clinic, but I think that we can find the pediatricians who want to work with us and we can co-manage together. We need to communicate explicitly. This is made a little bit easier by the electronic record to say, why do you want the geneticist to see this child? But as a primary care doc, I remember sending a baby with tracheomalacia to one of my colleagues, and I won't say which institution, but I sent this child, and they picked up the phone, and they said, Jennifer, have you lost your mind? Do you not know what tracheomalacia looks like? I said, no, I know exactly what tracheomalacia looks like, but this child's cousin just died of SIDS. So when the mother comes in and says, this kid's making this funny noise, reassurance from me was not going to get it. They needed to see the specialist. So I do think we have to have that bidirectional stuff. John Foreman and I talked together at the American Academy because John could pick up the phone and say, Jennifer, don't you know how to handle proteinuria? It was a very collaborative thing. He didn't say it more than once. We need to clarify our roles and responsibilities for our families, our medical homes, our specialists. Our families who are here will tell you that the question is, who am I supposed to call? He has a shunt, he's vomiting, he has a headache. Do I call the neurosurgeon? Do I call Dr. Antonelli? Who do I call? And we have to be explicit about that. Clearly, we have to support the care beyond the encounter. The child spends somewhere between 20 minutes and an hour with us, and they spend the rest of their lives outside the hospital. And then focus on the very unique needs of our children with medical complexity. As much as I worked in an absolutely lovely system for children with special needs, many of the children I take care of now who are, for example, I have a toddler who has a GJ tube, a central line, and a home ventilator. He walks. Chase that child around. I couldn't have taken care of him in my practice. So we have to recognize there's a place for our children with medical complexity. So in changing the systems, we talked about those things. We talked about population registries and stratification. One of the things that I really think we've got to get better at is this bidirectional electronic communication. There's a lot written about you sent it, I didn't get it, I didn't get it, you sent it, those things. This is probably the most important thing I'm going to say today. Caring requires person support. We've built so many wonderful tools, and they're great. You have to have processes, and you have to have people to carry those, to use those tools. So I'm going to say that again. Caring requires person support. We have to collect data on outcomes and value to be able to establish the funding, and we have to make it easy to do the right thing. So many of the things, especially in electronic records, I realized the other day with ICD-10 that I have to do 6 clicks to document an otitis just on the coding of it. Really? So we have to develop standardized common tools that we use. Build decision support in those, much as Amazon.com does. We need algorithmic care for triage. And we need to commit to accountability. In our quality improvement work at Cincinnati Children's, we sat down and looked at the teams that we'd worked with, and we said, why did this work? Why did this not work? And having team leaders who are dedicated to hardwiring change, who are dedicated to standardization and accountability, that's a huge jump ahead. You've already got a head start. So this is a summary of the things I think we need. We need to know our patients and our populations. We need to communicate well with each other. We need to work with our families as partners. The name is never right. We are colleagues, we are peers. They know their children the best. And then optimize all of our team skills. We need care plan leaders. And I will never go away from the all teach, all learn, because so many parents have taught me so many things. One mother told me last week, if you will just put swim goggles on your child, they will tolerate their BiPAP better. And brought me a picture of her child with her swim goggles on, and the BiPAP mask doesn't push on her face, and life is good. We need to share the resources. I learn every day from my parents. Share the resources in the medical neighborhood, and then work hard on our evidence-based care at the most appropriate site, which is why I would appeal to the 57% of our pediatricians who want to help us with our sicker children. And then measure and improve our outcomes and our spending, and innovate to create a patient-centric system. And when I'm thinking about that, I'm thinking about things like telehealth, like home visits we're going to hear about, Skype, even texting when we can get it precise. This photograph is from one of our families who I love, adore, and miss. And now 2 of these kids are married. I asked his mother, I said, she said, well, we got our picture taken the other day. I said, well, bring it to me. Well, I said, why did you bring me this one? It looks like things are not good. Dad was taking the picture, okay. These 5 children have 27 specialists among them. And the young man who has Down syndrome decided that really he didn't want to stand up anymore. He wanted to sit down on his brother, who was a micro-preemie, and the whole system fell down. I said, Libby, why this picture? She said, because this is how we live. This is every day. And so I treasure this picture. I keep it framed in my office. And Libby did say, my family, with all its challenges, is a success story, but part of that success is because we have had a medical home. So, references, and we'll take questions after our group.
Dr. Boling.
Well, thank you, and I'm going to apologize once for my voice and the possibility I may cough quite a bit. A virus came my way. I think for about $1,000, there's a 20-item respiratory virus panel I could have done, see which I have. And I'm here with pediatricians. I'm a geriatrician, so I'm really stuck badly out of water. I hope I don't go too far afield. So my head, right now I'm echo chamber. Everybody hear me okay? Yeah. So I was thinking, what would be a good metaphor? I'm thinking about Cat Ballou. Anybody ever see the movie? The guy prone, Jane Fonda throwing water on him and saying, your eyes look terrible, and he's saying, oh, you should see him from my side. All right. So I'm I'm going to talk about a different kind of medical home, if you will, that I think bears consideration, and I'm not sure that I could prove its value in the world of pediatrics. I was just getting very depressed listening to Tim with all of his data and his skills and knowledge, saying you can't find a difference. I want to challenge him. I bet he could if he did the different kind of care model I'm going to talk about. We'll see. That's a helicopter taking off from the roof of our place. These are my disclosures. And so yesterday, this conference has been great. I wanted to also thank Ed for inviting me. I learned a lot, and I'm going to take a bunch of stuff home. So that business of defining what the heck do we mean by complexity is a real issue. I think Tim was saying that he can't let the doctors pick on their own too much because they'll put too many people in a specialized care program and sort of drown it, I think, is what I was hearing you say. I think that's right. Been looking for the right term for what I do. I guess maybe complexivist is the best I can. A homicist isn't working for me. I don't like to be called a snifficist. I go to skilled nursing facilities when my patients go there, as do my team members, but it doesn't seem right to be a snifficist. So also said yesterday was a very important thing, which is we talk a lot about care coordination. I heard people today, speaking of personal stories, calling up, you know, hey, your rheumatoid arthritis is really seems to be a problem, not really bothering you with questions about the strange parasite. So I want to just stop for a second and have a little audience truth time. Show of hands, how many people in the last year or two have managed a family member, if you will, as a support system or a care coordinator, a family member who's been having complex health problems in the healthcare system? Good, keep your hands up. Now, everybody that has found that to be easy, keep your hands up. Everybody else put your hands down, okay? So we're pretty smart, right? Well-educated. I have 5 well-educated SIBs who, you know, came pretty well endowed from our parents, and my mom is living in a nursing home now at 106. She's a retired Harvard professor and has dementia, and she is declining. You know, I found it very difficult, though I know a lot about healthcare, to save her from the healthcare system. We saved my sister this summer. She almost died. She would have died without our family's constant involvement. And healthcare is dangerous. So the people that commented about the necessity of us thinking twice about what we ask of family caregivers and patients in terms of self-management and navigation, I think had it right. I want to double underline that. And I'll also underline what was said yesterday about the social determinants. Somebody on the front, I think it was Chris, said that he had, committed the sin of mapping by zip codes because that was all he had. And I will say that having been into the homes of lots of people, I've seen incredibly effective self-management and care coordination done by people who have no higher education, no special resources, and who are living essentially in third world conditions in the middle of an urban city. And I've seen equally terrible care and care coordination in the homes of people who have nothing but of assets. They're just loaded with assets. So the social determinants thing, the positive and negative variance that was discussed, I think is a very important thing for us to manage. And as we go forward, the last thing I'll say about this for this slide is, in my family, when we start to do a project, my oldest sister usually comes on the line and says, so who's going to manage scope creep? And my brother and I always think we can do everything, and the project gets bigger and bigger and bigger. I'm thinking about the things that we can fix and the things we can't fix. So the old house really needs this wall fixed, but then when you get to the corner, the other wall is equally bad, and you're running out of time. So the social determinants of health is one of those areas where you can put all of your resources and all your energies into fixing something that can't be fixed and isn't even within your scope of capacity to alter. So you have to be real careful. And finally, if we put the patients and families first, we'll be right most of the time. So these will be the most important points for my part, to take home. The patients that we manage in my geriatrics practice need an advanced medical home that is patient-centric, and for one of the things I will add to the conversation today, which I haven't heard said before in the conference, is that sometimes that means you need to go to the patient's home. When they're not very mobile, or when they're having unexplained and recurrent utilization problems that you just can't sort out in the clinic, even if it's a very comprehensive clinic with a lot of skills, if you don't go to the home, you're never going to get it right, because you're missing half the story when you try to do it from the clinic. A nurse care coordinator in a center with a great algorithm and a great data capture system will usually not succeed. That's actually been tested pretty thoroughly and failed, as you all know, sitting in this room. And so also something learned from going to the home is that the concept of trust is incredibly important. You're asking somebody to make decisions about healthcare. If you're trying to control costs, you're asking somebody to make decisions about healthcare that have to do with accepting care in the least resource-intensive and least costly environment that's going to be adequate to the need. But this person that's making the decision is not a medically trained person. They're counting on you to assist them or help them figure out what is the right thing to do. Do you need that MRI? I think one of the speakers earlier today mentioned, well, not really. You really don't need the MRI. Well, is it okay to forego the MRI? Do I trust you enough to say this MRI is unimportant? The neurologist said you need the MRI. The hospitalist said you need the MRI. Do you really need the MRI? That's the kind of question. I think in the end, if we do this well, we are actually going to be able to save money, and we should be able to prove it somehow if we have the right comparison group. So I'm going to show you an example of one such. Somebody mentioned at the beginning of this that the pediatric population only commands a small slice of the pie of costs. Within that pie, that small slice, though, I've got to think there's a juicy chunk that probably pertains to utilization of hospitals, which may be ameliorable, since the hospitals are where the biggest piece of the costs come in. So a social support and health care model in combination, obviously the key. And now I'm going to tell you about how I got into making house calls. The thing on the right is the award from the McKesson organization that's given out by the American Hospital Association for the hospital that's demonstrated the most success on the journey to quality and safety in the preceding year was won by our health system last year. And so I'm proud of our hospital. We've done all kinds of great things with reducing ventilator-associated pneumonia and IV line infections that occurred in the hospital and things of that sort. But what I learned at the beginning of my training was I can cure pretty much anything, and the health system is fantastic, the clinics are fantastic, the hospital is fantastic. I started making house calls in 1984, and the patients I was seeing at home, I found in the clinic by virtue of them being on stretchers or on wheelchairs when they came to clinic, and I sort of went over to them and said, would you like for me to come to your house instead of you coming to the clinic? And nobody ever turned me down. So after about 6 months, that particular clinic had no more stretchers, no more wheelchairs, and I was starting to see the world differently through the eyes of these patients and their families when I went into their house. What I found there was that what I thought was going on, what my colleagues at the hospital thought was going on, was most of the time wrong, and the patients had poor access to care. So think about what it looks like to move a relatively immobile person on a time-sensitive scale to a setting where they can get health care. It's challenging. So you want to make an appointment with the doctor. The doctor says, yeah, we can see you Monday at 3, and is there going to be a transport that's possible to bring you there? Is the daughter going to be able to get off work? God forbid that you really need to be seen tomorrow morning because the problem that you're having is developing acutely and needs to be addressed immediately. That's almost impossible, even with open access scheduling, right? So my experience of healthcare seen through the eyes of a house calls provider was that the healthcare system for this group of patients, I'm not going to use a swear word because we are being recorded, but it was really very poor. It was not a, you can imagine what words were coming to my mind. The healthcare system was not serving these patients very well. And well, this is not hard. We need to have more of this. We have more people making house calls. We'll cure all these problems of these really sick, chronically older people who are not very mobile. They won't have to come to the emergency room so much, clog up the hospital, shorten length of stay, decrease costs, happier patients, and so on. Should be straightforward. Started trying to convince my colleagues, and they all said, well, that's great, except, we get paid next to nothing for doing this. And so then I spent about 5 or 10 years trying to get the Medicare program to pay more. We actually were successful in doing that. We got the rates about doubled. And a lot of podiatrists got a lot of money for making home visits as a result, as did other physicians. But it was not enough, because the piece that you don't have in the fee-for-service system is the support that goes around the team, the social worker, the nurse coordinator, the people that can't bill for their services. It was already the cup half full in the preceding speaker's comments. Those other people, they have no mechanism for being paid under fee-for-service. So if you're going to have a team, you have to have a payer source. The CEO is very clear about that. So this particular row there is a place where I made home visits in Richmond. These old people are actually internet clips. They're not people I know. But the stairway that the older person would have to be brought down to come to clinic is real. And so the patient's discharged, and the hospitalist puts in the instructions, says, see your primary care physician in 3 to 5 days. And the wife is up on the second floor there with this guy, and she's thinking, all right, so how am I going to do this? He's hemiplegic. He weighs about 240 pounds. And here's the wife, and, she's average sized, and there's just no way, right? So that's a bad care plan made without knowledge of the circumstance in which the patient lives. So there's my dad in the center, who taught me, if you want to do a job, always use the right tool. And you get the idea. So I'm going to say that if you got that guy on, all right. My dad actually used to cut down trees that big with a handsaw and an axe when he was 20 up in the mountains of Washington State. So these are tools that are not exactly right. They can be complementary and supportive, but they will not work by themselves. The PCMH model, I've heard lots about PCMH today, is fine for the general populace. It's designed really correctly so for 85% of the population, including people with chronic disease states, but not yet chronic illness, who have not reached the point of those guys in the wheelchairs and stretchers. Most of those practices that are PCMH wouldn't be able to manage the patients that I take care of, because the issues are too complex, and you really can only get to those issues by going to the house. It's not possible when you have a patient schedule like I'm going to have tomorrow afternoon in the clinic, when my day is going to, in the afternoon, start at 1 in the clinic, and I will be running hard until 5:30 to get home. That just doesn't comport with the needs of a patient who's homebound and immobile. I'm going to say that probably there are going to be some kids like that. So I do med rec in the clinic. Do you guys have medication reconciliation as a requirement for meaningful use, which is supposed to be worth $35 million to our health system, so we get reminded every 20 minutes, did you do your med rec? So the med rec that we do in the clinic is based on, at best, a brown bag that somebody's brought in. And sometimes it's right, but I will tell you, having been to a lot of patients' homes, that it's usually not right in this kind of patient population. So I had one lady, she knew all of her pills inside and out. She put all of them in a big glass jar, about a quart and a bit. And the old Dilantins at that time were a cap seal with a pink stripe in the middle. And she could tell me exactly what each one was for. That was all fine right up to the point where she started to get dementia. And then her selectivity on the pills she was taking became less precise. And there was one person who was taking all her meds. You could tell they were taking all their meds because the prescriptions were being refilled on a regular schedule. They were putting all of their ACE inhibitors for the week in Monday, and all of their beta blockers for the week in Tuesday, and all of their diuretics in Wednesday, and that wasn't working out very well. There was another person that we talked about recently in our team meeting who had sort of 20 or 30 bottles that got all collected together, and then the person mentioned, you know, that they found a whole basin full of additional bottles in the top drawer of the dishwasher, which is where I usually keep my pills, you know. But so when you go to the home, you find out what people are able to do as well as what they are doing. And I'm going to say that there's no other source of that information other than going to the home. So there's a kid, and I pulled the picture off the internet, but I heard described recently the kid, right, ventilator and a IV line. And here's my imagination of the moms thinking about the care coordination activity and managing the craziness that must be their world when they have a sick kid that needs to be moved somewhere to go get health care, especially if the need is urgent, such that if they don't get something done, the patient's going to have to be taken to an emergency department. That really calls to me for an accessible healthcare system that's mobile when the patient is not. So our house calls team has wrapped around it, as has been mentioned several times, as Tim mentioned, a network of services. And we've talked about making that same kind of resource catalog, if you will, but we want to annotate it and say, well, these guys are good and these guys are not. And yeah, you can't publish that, though, I'm pretty sure. So these resources are around us in the community. We all know about them in our house calls team. We use them. We're close to them. And we know how the system works so that if you need to get help to somebody, we can make that happen. I'm saying we're specialized. So then you have to talk to a bean counter eventually. And the bean counter is going to want you to prove that you're doing good work. And they're going to want you to do a lot of documentation to make sure that you have demonstrated the value of the work you're doing. Now, I used to have Gary Larson cartoons in pretty much every talk. I've loved this one for a long time. It reminds me of the craziness of some of the work that we do nowadays. Call made to neurologist to schedule appointment for, call made to schedule the VCUG and the MRI on the subsequent day, and 2 days later with the brain surgeon to deal with the normal pressure hydrocephalus. So we do have to document the value. And there is evidence for the house call model. So I'm going to mention Mary Naylor's work at the University of Pennsylvania. Some of you know Mary Naylor. A decade or so before Mary published her landmark randomized controlled trial, the same group, one of her colleagues, Dr. Bruton, published some work on early discharge of complex kids. And I see some nodding heads. There may be some people from Pennsylvania here. Tom Eads just published a large study on VA-based patients who get home-based primary care, and Eric DeYoung and George Tyler about the same published a study on patients that are receiving house calls in the MedStar Washington Hospital Center. And you can see 17% reduction in total care costs and probably closer to 30% in the most complex. So with that in mind, we wanted to find another way to pay for this. This is the PEDS article. We wanted to find another way to pay for all this team-based approach, and what we came up with was proposing to the Medicare program. I know that Medicaid is a little bit more complicated, being as there's 50-plus Medicaid programs, which is why we went after Medicare. Gotcha. And we proposed a model that was going to be uncomplicated for patients, so voluntary participation, retaining their insurance, agreeing to have their data analyzed, targeting a selected subgroup of patients, so in the hospital in the last 12 months, using post-acute care, which actually provides us data on functional status, having residual functional impairments, having serious chronic illnesses, not just high blood pressure or arthritis, house calls team model, and basic medical technology, including EHR, quality measures to protect the beneficiaries, and guaranteed minimum savings of 5% after that shared savings. So the results have been good. This was the original legislation, so we had bipartisan support for this really cool idea. And this was what came out in June as preliminary findings. Compared to the ACOs at $414 per member per beneficiary in the first year, about $3,000 in our model. So fairly good. Most of the programs were successful. Some were really successful. Our group that constitutes the University of Pennsylvania, Washington Hospital, MedStar, and VCU, we reduced costs according to the estimate of the analysts about 20% total costs. which is pretty fabulous. And we got a check for $1.8 million, which helps to support a team-based approach. So I'm suggesting to you guys that this might work outside of Medicare if you can find the right group of kids and go visit them at home. This is a list of where we save money, and the slides are going to be in your slide set. So I'm going to click through, show you that the press loves this, making house calls to little old people. Who would argue? And we've had the demonstration extended by 2 years, bipartisan support, solid bipartisan support. And I'll stop. The only pediatric experience I have.
Well, thank you so much. It was great to hear from a pediatrician, a med peds, and a geriatrician. So whoever put the panel together put the right mix of providers there. I think obviously one of the themes that we heard throughout it all was actually the family-centered piece of it, and actually how does the home visiting, the home visiting words are in my mouth from the Maternal Child Health Bureau, but how does the home visits, how does that make a difference? So I would challenge all of you to look at that as a model of care. And then the other thing that all of you talked about was return on investment. And there is a return on investment. It may not be in dollars and cents, but it's in the quality of life and the quality of care that the family receives and how that plays out. So I turn it over to Dr. Rushton.
Okay, well, thanks. I'm Francis Rushton from South Carolina. And I can't tell you how excited I am about this afternoon's presentations because everybody used the word relationship within their presentation. I've never been to a meeting where I heard this word used so many times. And I really do think that the relationship, not only between the healthcare provider and the patient, but between the whole healthcare team and the patient, is a primary determinant of how that patient feels about their functional health. But I only know of a modicum of data to support that assumption. What little I know, I think, comes from Barbara Starfield. I understand there's more data in the family medicine literature. If I'm making this case for the importance of the relationship, where do I find the data to support that notion? How do I maximize the relationship between the health team and the patient if I think it's important, and how do I teach it?
Maybe I'll start.
That's a really good question.
Okay. Like Johnny Anian's JAMA editorial that pointed out, there is a growing consensus among researchers that relationship is a critical component. But the evidence is largely indirect because it's not measured directly in most of these trials. But the way it's generally framed is, the Congressional Budget Office actually published a meta-analysis that looked at disease management programs, and they created a classic spine diagram of the effect sizes across, it was about 30 different programs. And what was clear from that CBO report was, and I don't think any of the trials were pediatrics in that particular one, but what was pretty clear, thank you, that's helpful to see your face and when I'm answering your question, is that the effect sizes that were better than null tend to be programs with embedded care coordinators, and embedded care coordinators know the patients. So it's an indirect, whereas the sort of classic nurse on the telephone, unknown to the patient, trying to give them advice, like, would you take that advice? And so I guess what I'm saying is there does seem to be a lot of indirect support for it, and John Anian wrote a very nice JAMA editorial about that fact a couple of years ago. But I'm not aware that there is a publication that has specifically identified that as a feature. So it's more something that's come out of the meta-analyses.
So it's the work of David Tom and UCSF, T-H-O-M.
T-H-O-M, David Tom. Okay, there you go. Not surprising in a group of experts that the experts are all around us. I'm absolutely convinced it's a requirement in our programs that there's a relationship development piece. There is a lot of practical implications to that statement. Building and sustaining relationships has, as a precondition for everything you do, has all kinds of implications for how these models are elaborated. So how do you deal with turnover of your staff? How do you deal with the fact that, for example, in pediatric, our embedded pediatric program, the rate of these children is low enough that we have to spread a single care coordinator over as many as 10 practices. If you spread that person over 10 practices, how do they develop relationships, and not just with the patients, but with the other doctors? Because it's very important for the doctors to trust the care coordinators, and the only way you develop trust is through a relationship, right? And so we actually have relationship building exercises, both between care coordinators and providers, and between patients. We also our care coordinators who have to go between practices get weekly schedules of when their patients are visiting the doctor, so that they can plan their week schedule so that they intersect with the patients while they're in the waiting room. And then finally, there's no better way to develop a relationship than actually going to the home. And so we encourage our care coordinators within their first year of a new relationship to do at least one home visit. So there's all kinds of ways to foster relationships, but it is hard, and it is something that requires a conscious strategy and investment.
Great, thank you.
Hi, Simon Hambidge from Denver. Thank you for a thought-provoking series of talks. I wanted to come back to the question of how do we pay for care coordination for kids? And yes, we can make the moral arguments, and we need to say this is just what we need to do, but it sure gets easier if there's an ROI. And I'm intrigued by Tim's statement that there's no ROI to be found. I guess I would just push back, and I think maybe the home visits is a good model. I mean, there are kids with Down syndrome in our institution are hospitalized at 10 times the rate of kids that are healthy. And so there's got to be subsets in there that we can find. And if you can find those subsets, you can actually use those cost savings to cover other kids. And maybe in integrated systems, for years in FQHCs, we've been cost shifting from kids to adults. Maybe now it's time to start cost shifting back the other way. So you take part of your $1.8 million and buy a couple of nurse care coordinators or something. I just want to throw it out there. I think there are innovative ways to find ROI, and so I just put it to the panel to think about that.
So let me just say that I was being purposefully provocative, so we could have this discussion. So when I was talking about ROI, I was specifically, just to be clear, talking about financial ROI, not the return on the investment in other ways besides finances. So let me just say how we finance our program. We're at risk for 500,000 lives and the costs of care for those. We believe this is the right thing to do for all our patients. We get a very large ROI from the care coordination work we do on the elderly, and we use that to fund care coordination for everybody. We believe we, as a delivery system, get an ROI as outcomes and satisfaction from our patients. But I will come back to that very narrow thing now and just say, as a med-peds person who looks at costs of care across an entire population, the pediatric advocacy community looks at the very high-cost kids and say, these are really, really expensive kids, and there's got to be a way to do this. And I'm afraid I will tell you, the really, really expensive kids don't even come close to the really, really expensive adults, not even remotely close to the really, really expensive adults. It's just simple, I'm sorry, that's just the way it is. You think you've seen expensive, you haven't seen expensive. And so that means that producing saving a couple of hospitalizations in adults when, what the most common reason for hospitalization in a Medicare beneficiary is?
Fall.
Fall. It's a fall. They spend 3 days in a hospital, and then they go to a sniff. For a fall, 86% of those falls do not require acute care, period. They just can't go home, right, because they can't walk, right, or they're alone, or whatever it is. That's an extraordinary number of hospitalizations in the elderly population. So just to give you a sense of scale, hospitalizations are really common, and they're really in the elderly, and they're really common for things that actually don't require hospitalizations. Now think about that in kids. We do so much work to keep kids out of the hospital already. When they get hospitalized, boy, they generally really need it. And it's hard to avoid those. And now there's great work around, you know, the variability in hospitalizations for asthma and stuff like that. But honestly, it's still really small rate compared to what's going on in the elderly population. So I will just come back. I will defend my statement. On a purely financial basis, it's really difficult. So to find, and I think they can actually break even. I think you can probably, for the funding, our models come pretty close to breaking even. But in terms of actually producing a savings that are going to accrue, I can't find it in the models. So anyway, that was a more deliberate or lengthy description.
Dr. Keller?
Hi, David Keller from Colorado. Wow, I could talk about so many things, and thank you for raising the issue of house calls. As a pediatrician who made house calls for many years, including pronouncing a child with Duchenne's muscular dystrophy who wanted to die at home, I can just tell you it's incredibly rewarding, but doesn't pay for itself. You just kind of have to do it. The question I have, though, gets to the issue of co-management that we were talking, that this panel was talking about. We have these complex children with complex teams, and one of the things we're struggling with is the who's the captain question. Now, of course, the captain is always the parent, but somebody's got to be the pilot. Somebody with expertise is going to be the guide. And one of the concepts that's been floated around is this sort of idea of locus of care, that the care management, that there's some place, sometimes it's in a subspecialty, sometimes it's with a primary care doc. And one of the challenges is identifying with the family who's going to be driving at any particular time during a child's clinical course. I'm wondering if you all have thought about that at all, and what your thoughts are on how you've managed that, and how do you make sure everyone on the team knows it, so that we kind of have agreement on these complex, diverse teams that we're putting together for the children?
One of the things that's happening, and many of you are probably involved in this, is there is a grant, a CMMI grant right now called the CARE Award.
And full disclosure, I'm on it too, and it's the one piece of it that we can't figure out.
And it is very challenging to say, it's easy to say who's on this child's care team. Oh, he sees cardiology, he sees nephrology. I think the question of empanelment, which the Commonwealth Fund wrote about years ago in terms of saying, I am your doctor, that's something that the CARE Award is prompting us to look at, to say, okay, who's in charge? Who's going to step up? Who is the person that the family is to call? And I think that the necessity of actually writing the name down in the electronic record and saying who's on the care team also calls the question of saying who's in charge. And I don't think we have any answers, David, but I think that the very fact that we've got, 10, 13, I can't remember how many children's hospitals working on that to say who is on the care team and who's leading it, I think it's a tiny baby step in the right direction. I do think the concept of empanelment is really important. I know when I was in practice, we argued about it because everybody had been sort of in the big pool. And when we went to empanelment, we found it to be incredibly, incredibly valuable for the patients to know who they are going to see. And we did team-based empanelment so that if Dr. X is not there, Dr. Y is on the team, and the nurse and the scheduler, and we had team-based care that way. I think team-based care gives people a lot more opportunities so that if you're not there, that they still are not, it's not a closed door.
Speaking now only from the adult world, and therefore dangerously far from my comfort zone talking about kids, but we have a number of subspecialty areas where coordinated care has become important because of the readmissions problem in the hospital. So heart failure is an example. And the discussions we're having center on whether you're going to be responsible for the whole person when you're the first call, or only the thing that's of interest to you. So my take on this, when I've been discussing with the management of the health system and the cardiologist, is if you want to be the first call, you have to be the first call for everything that might come up. So if you think that the heartburn is angina, that's fine. But if you think it's really gastroesophageal reflux disease, you still have to manage it. You can't dump that back on me, because we're going to be spending money to support an advanced care management plan. That money ought to be allocated to the medical home, which is about empanelment or who's getting paid to do the care coordination case management. So I think that we have to support these efforts when they are being put in place. There has to be a financial mechanism, because the time that really kills you is not the time you spend with the patient, it's the time you spend after and before, right? And so I think that whoever's going to own the first call has to own all of the calls for related kinds of issues in the particular patient.
Just answer really quickly. So because it's a great question, and I will say our default is that it's the primary care and the care manager as a default, but we do have exceptions. So interestingly, heart failure, severe heart failure is an exception. It turns out it's so super specialized. Our transplant program is an exception. We do not manage our transplant patients in our high-risk care management program, because I can't even pronounce the names of the meds that they're on. And also, as I mentioned before, cancer, we carve out. So those three we carve out. Everyone else is in unless, and then I'll go to something that Susan Edgman-Levitin can probably speak to maybe, but we are increasingly writing compacts between our primary care doctors and our specialists, and those specialist compacts, which we're still sort of feeling our way through, helps to define this very issue, like who's going to be the pilot, because we do get a lot of the specialist wants to be the pilot, except when they don't want to be the pilot. and so this is this going through this process of having our different specialty divisions speak with primary care and come up with a policy. It almost always starts off with a conversation of the specialist saying, we are in charge, and then we get into the details of what that means, and they almost always say, no, you're in charge. So it's a different, but the compact is a way to get that conversation going, the process.
Eileen?
Hi, I'm Eileen, parent leader from Colorado. In terms of this discussion, I wanted to just promote that the families would indicate it's their consistent source of care that they would like to see as their pilot. I've always said as a parent that I prefer to refer to medical home as a verb and not a noun, that what I want is a medical home approach no matter where it is. And in my daughter's case, the neurologist was our consistent source of care, and that's exactly the experience we had. He didn't want to be her primary medical home, and our PCP didn't want to be either because of all the other complications. So at the age of 26, my daughter is still not settled into wherever her home is going to be, so I remain her primary care coordinator, just FYI. The other piece I wanted to talk about was this notion about the home visitation. You know, as a child who's been in the system her whole life, we started with home visits through the Part C program. And I just want to say that, you know, that evokes emotion for me as well, because that's kind of vulnerable to allow person after person to come into my home. And I have other children. I have to be home. I have to take a day off for work to have the home visitation. It's a lot of work to even schedule a home visit. And yet, you know, I've got other kids that I'm managing and doing all of that other piece too. And then it's interesting that as we look through the life course, what strikes me in this adolescence going through transition is that the biggest lesson I had to learn as a parent was how to be bilingual in the healthcare system. And I don't mean English versus Spanish. What I mean is deficit-based language and asset-based language. Because in the pediatric system, we have this entitlement of things that she qualifies for based on diagnosis and otherwise. But the minute we got into the adult system, if I started talking about the things that she could do, her benefits package shrank to about this big. And so I think that's also a disservice that we have, is that we're not teaching and training families or providers about this Medicaid game that we play, and how crushing it is for me as a parent to have to shift overnight to talking about all the things that I really want her to be able to do, but if I mention that, Medicaid isn't going to pay for that. And so just a month ago, we had our annual home visit by our Medicaid caseworker, and the assessment, what I feel the minute she walks into my home is she looks around, oh, wow, you have a nice house. Oh, I notice your daughter's nails are painted. I mean, just moment after moment of making an assessment that somehow I am, I don't know, not being appropriate with the utilization of the Medicaid fund. So I just want to share that from the parent perspective, that it is different in Medicaid versus Medicare, because I'm constantly fighting for her benefits in the adult system, because we don't have that anymore as we did in the pediatric system. So I wanted to mention that. And then similarly, with the health policy, when we've had poorly run interventions at our hospital, the response to me from my wonderful healthcare providers is say, Eileen, you really should talk to the ethics committee about this, and we should be able to do something. I say, I know that I can, and I know maybe you'll change it next time for my kid, but this is a health policy issue. And there needs to be reasons why a young lady with developmental disabilities like my daughter, who could not get women's health services because we needed a women's health service at a Catholic hospital, and they wouldn't do it. And so for me to take that on at the ethics committee, it might have made that difference for my kid, but is it really going to make a difference for the whole system? And that's what my interest is how do we then cultivate the health policy that's been changed and impacted by the voice and advocacy of families, and can we learn from that and make those kind of sweeping health policy changes across the country? So those are my comments.
Thank you, Eileen.
So David Bergman from Stanford. Jennifer, I want to pick up on your study and talk a little bit about the 43% of primary care practices that didn't want to see these kids. What do you think we need to do to support those practices? What do you think the role is of hospital-based complex care programs to support those practices, the role of consultation services, co-management, and other things that we might implement?
My basic theory is to work with the willing. And so I think if indeed you have clinicians who say, I cannot take care of a child who has Down syndrome, you need to go to the medical center. I think what we need to do is identify our allies and find the places where we can say, I think you might find X or Y or Z group of pediatricians willing to work with you. And I think resources should be thrown at supporting those people. Dr. Perrin and I had an interesting conversation about the numbers of pediatricians who are going into salaried arrangements rather than smaller practices. I think the other dilemma on that is geography, because many of our families live in places where you have one doctor or one provider, and that is tough. In that situation, I think we have to develop co-management programs with the complex care centers, even if they are at distance, to be able to say, until we can get the helicopter to you, this is what I would like for you to do, and develop really very personal relationships. Hi, my name is. I'm working with a doc in Tennessee now who's a fantastic pediatrician, but had never, ever received a call from the medical center about this little girl who is very, very sick. And I said, hey, we need your help. He signed on. But I think we have to extend the hand that says, how can I help you? How can we work together? And I know that's not compensated, but I think it's going to have to be necessary in the first steps toward co-management between specialists and primary care, especially in remote areas.
Great, thank you. We have about 8 minutes and 5 people, so you guys do the math.
So I've got 7.5 minutes, and
Then I'll go.
all right, good. I'm Danny Armstrong from Miami. I have always had difficulty with
the term transition. And this panel is one of the really good reasons. We do a lot of work in pediatrics where we talk to other child health specialists. You made the comment in your last picture that that's as close as you got to pediatrics. But the truth is, the reason we have a crisis in adult care of children with complex conditions is that in pediatrics, we've gotten them to survive to that point. I question sometimes how often or whether part of our plan should be that the pediatrician goes to the adult practice, meets with the parent of the 40-year-old with Down syndrome or the long-term survivor of childhood cancer or the 35-year-old with sickle cell anemia, to be able to see what the outcome is of what we've done in childhood. We had a study in sickle cell disease, a multi-center natural history study that looked at brain function and cognitive function, and we were able to show silent cerebral infarct and incidence of stroke, and we had this one group of kids who were declining over time but without any evidence of MR findings. And then we had another group that had no abnormalities. And a few years ago, we did another study with adults who were 25 to 40, and about 40% of the children that we had followed in that natural history within the adult study. And when we looked at that group, 33% had cognitive functioning that was below average and into the impaired range, and it was associated with increasing age and chronic anemia. And when we presented those data to Betsy Nabel, who was the director of NHLBI, her initial reaction was, every kid, symptomatic or not, gets chronic transfusion therapy or gets a bone marrow transplant. Now, that's a little extreme in terms of a reaction, but I use it as an example of the importance of this panel, going from pediatrics to med-peds to geriatrics, for us to think about the fact that as we think about designing systems that work, we've got to focus on what services do we get today, but we need to engage the parents and the children who grow up so that we can understand the outcomes and potentially come up with modifications so that the next generation has a better chance. So my comment and actually responses to that. There's a great opportunity for research, by the way.
Okay. Anyone want to comment? No. Richard?
Okay, yeah. Rich Antonelli from Boston. I will purposely be brief because I especially want to let Carolyn Altshouse speak. But I'm the child health subject matter expert at the Measure Applications Partnership at the National Quality Forum. And in that role, I never say I'm representing child health. In fact, most of the time I'm talking about geriatrics and Medicare. Because in this city, except during CHIPRA reauthorizations or meetings at which the Maternal and Child Health Bureau was either convening or present, nobody pays attention to kids. And I'm here to say that's okay. So Tim, something that you said is really important. When I think about care integration and performance measures and accountability, the first principle I go by is this possible that is exactly the same approach for adults as it is for kids? And for care integration and care coordination, if you pull out the content, so a NICU graduate versus an 87-year-old with dementia and status post a fall, for example, on the process side and the outcomes, they're generally identical. So I think we need to think about that instead of the child health community saying we're different, we need help. I would argue that in terms of the outcomes we expect from care delivery systems, they are identical. Then we just elaborate within the context of what those specific groups are. So this is a request to this group to think about when the geriatric community convenes, or organizations that are led by medical directors that aren't necessarily sensitive or have sensibilities in the pediatric space, that's okay as long as we can get a seat at the table. So that's my question to you. How do we strategically, the child health community, get a seat at those tables so that it doesn't have to be, let's convene a child health meeting? This group should be present at every single meeting around accountability, around care integration, around financing methodologies. And then we can figure out the models. Because in the end, care coordination is a lot like politics. It is all local.
Maybe I just say, so it's a great comment. And I do think, so if I heard you right, you are advocating that there's an opportunity here for the pediatric community to ride along the ACO, even though the ROI financial stuff isn't necessarily there in the ACO. If you're taking risk on a population, there are kids in that population, that system, like my system, which is responding to the ACO Shared Savings Program imperative by building systems in primary care, you're just saying, just remember your kids as you build that care coordination functionality, and basically, without arguing for something separate or different, just argue to be included in what's going on. That's the way it's working in my system. And frankly, I couldn't start with pediatrics. I had to wait 2 years because in order to prove to my board that I was going to get an ROI, I had to start with the elderly who were falling and ending up in the ED. But within 2 years, we were doing it in kids because we weren't going to do it differently. We're going to have one system of the way we care for a population, and that includes care coordination for high-risk patients, no matter what age they are. Yeah, great.
Thank you. Go ahead.
Hi, I'm Joanne Lynn from Altarm Institute Center for Elder Care and Advanced Illness. A couple of observations from the perspective of someone who's here on behalf of your personal future. Most people here will grow old, frail, sick, and be dependent for a few years at the end of life. And we don't have a care system that works there, and everybody's saying, well, it's sort of all the same. Well, one thing that's really different is the numbers. But the other thing that's really different is the presence of death and decline. So you do have some kids who are going to decline and die, but there's a chance they're really going to live a long time and have a life. There aren't a lot of such options for my 90-year-olds. So dying is a big part of the conversation. And it has a couple of very interesting research components that we always push off to the side. One is that all of our quality measures are screwed up by dying. So the best performance on things like pressure ulcers and falls and quality of life and caregiver burden and so on is all if the person dies quickly. And if the person instead lingers a long time, all your measures get bad. And we have not actually focused on length of life as something we choose to measure. Obviously, the costs also go up, so costs are a big component. And that actually also fouls up something that Tim said, which was the regression to the mean. In my population, the acceleration of expenditures as a person gets close to death really fouls up your metrics on costs. And obviously, once the person's dead, costs really go down. So the interaction of death with quality measures and costs is a really complex idea that we have mostly marginalized. As a matter of policy, CMS refuses to include anything to do with the length of life in their policy or their economics, which is what I call the Presbyterian approach to death. It says if no matter what we did, we're going to die on a certain date. And that may work in some worlds, but not in mine. So death, I think, is so present in my world that it really makes it different than children. Second thing is the role of community. Most of you work in areas where your facility is the dominant provider for complex kids. And most of my world just does not work that way. Every hospital, every doctor thinks they can take care of frail old people. And so there are these massively overlapping systems. So there's no geographic responsibility. And yet, at a certain point, people really need to be seen by Peter. People really need to be seen at home. And once you have to see people at home, it is massively ineffective and inefficient to send people different providers, depending on whether they're veterans or insured by United or insured by Partners or whatever, or associated with this hospital or that hospital. If there are 10 people down the street who need to be seen today, they better be seen by the same team. Because if you send 10 teams out, you're spending all your time on windshield time. So thinking geographically starts becoming terribly important. And unlike Tim's claim that there's all these services out there to nab, in my world, that just isn't true. In Washington, D.C. today, we have a wait list for Meals on Wheels. We have a wait list for housing. We have people going into nursing homes because there's no other alternative. We have to not only learn to use those resources, but we need to actually be advocates that they exist. And I think one of the biggest gaps in patient-centered medical home is there's no obligation to actually fill the table. There's an obligation to skillfully manipulate the cafeteria table so that your patients get the right stuff. But we really have to fill the table. And that gets me to my last point, which is I don't know how many people here know about Project ECHO. Have you learned about ECHO? I mean, the democratization of information would really solve a number of our problems with the rural doctor or the doctor who sees only a few such patients. If it was easy to tap into expertise and to have that kind of support, then we could have lots and lots more doctors and nursing homes and home care agencies and hospices at a skill level that is very high. Instead of requiring that the patient come to you in order to punch a button and get paid, if there was a way to spread that knowledge. And with the internet, it's not going to be able to be kept in fences any longer. We're going to have people who really get at that knowledge one way or another, including by getting expertise from out of the country.
Thank you very much for your comments. Carolyn?
Hi, I'm Carolyn Alshouse. I'm the Executive Director of Family Voices of Minnesota. Our organization's a nonprofit organization, and we house Parent to Parent. We're part of Parent to Parent USA. We also are co-lead for the Family to Family Health Information Center in our state. And organizations like mine all around the country, in every state, are providing exceptional support to families, helping them navigate very complex systems that we've been talking about, helping them find insurance on very, very small budgets, and cobbling budgets together to keep our programs afloat. In our particular organization, we've been collecting data over the last 4 years that has shown pretty remarkable results related to increasing competency in families, or their feeling of being able and competent in caring for their children and their families, accessing services. And we've also shown a decrease in ED visits for families who have participated in our program. So when I think about return on investment, I think about programs like ours that I think health plans would be wise to consider funding and helping to fund. MCHB has long time funded programs like ours around the country, but our budgets are very, very tiny, and we're doing pretty mighty work. So I'm wondering if there's ever an opportunity to look at how health plans might look at our organizations and the return on investment that we bring, as well as the Medicaid program, looking at those factors as well. So those are my questions.
Great. Thank you, Carolyn. And I think we're out of time, unless you have something you can say in 1 second.
Real quick, and it's a good follow-up to Carolyn's, and it's the point on the return on investment. I'm a child and adolescent psychiatrist, as I said yesterday, but also an adult psychiatrist. Caring for these kids is incredibly, overwhelmingly stressful. And when we try to assign a return on investment of something like care coordination without addressing what is the impact on supporting the behavioral health needs of the parents providing this care, we're missing the boat. Because there is where the true return on investment is. You can provide all the care coordination in the world, but if the mom or the dad is horrifically stressed beyond belief, they can't follow through with no matter what kind of supports we try to provide for them. I do think care coordination provided in the right way, and co-management and team-based care provided in the right way accomplishes that. I don't think we have figured out how to really measure that effectively. So that was my point.
Thank you, everyone.